Fabulous. Thanks for joining us. I know there's a lot going on, and we've got a couple of a few different presentations to get through today. So I'll be Craig for the day, and I'm going to hand straight over to Donna in the interest of getting us out on time. Donna talking about the patient pathway review in oncology. Over to you, Donna.
Can everybody hear me?
Yeah.
Good. Okay. So I'm Donna and I'm Business Support Manager in Medical Physics and Clinical Engineering. So we're in Oncology CSU. And my LIM Report Out is based on the patient pathway to review some efficiencies. So slide 2, please. So the problem and challenge, I'm not going to read from the slides. I've just got a little bit of an overview so if you want to read them. So the radioiodine inpatient service had potential duplication of tasks. It was quite task heavy. So we decided we're going to have a look at it, review the pathway. I met with the team in the therapy department and we walked through the current process. So from that, made lots of notes, drafted a pathway on Visio and had a chat with them really about the recommendations. It was kind of task heavy. Let's have a look at what we can do. So this linked to the 7 Cs, which was the sustainability. So let's utilise assets efficiently and we can keep it maintained. And care. We didn't know it would be the care bit of it, but we ended up getting some really good outcomes with getting patients home 1 day sooner. Next slide, please. So actions. We identified some duplicate tasks. So there was things like we had paperwork that was then filled in, typed into a spreadsheet. So there was things that we could have done better for that. And we identified some tasks that didn't add value, so some triple checking and things like that. Liaised with informatics regarding the digital reporting, so let's get it digitally reported, and liaise with the patient services coordinators in non-surgical oncology to review the drafted pathway, because obviously this links into other areas as well. The LIM tools that I used, so we used the stakeholder analysis, so let's identify who's involved, everybody who's involved in the process, in the treatment, in the care. Did a walkthrough with direct observation, so walked them through the process, made lots of notes, and from that developed a flow chart, so we could just see it a bit more clearly. We agreed the outcome with the team, so we looked at what we wanted to achieve, obviously using our lead to way behaviours. And the outcome, we'd said, let's achieve a leaner, efficient pathway. So that was what our aim was for this piece of work. We ensured we had high level support, so we linked in with service managers and just really to aid the implementation of the changes and keep people updated with what was going on. So to sustain this new process, we've kind of identified we need to do the key DCAs, so the plan, do, study, act cycle, and that would be really good to do quite regularly. Next slide, please. So the outcome from this piece of work, we did create a new pathway. So we've looked at it, made some efficiencies, and we have implemented this. We've removed some of the tasks and made them leaner. So we did an inpatient clinic, moved that to PAS. We completed some referral confirmation letters to patients. This just reduces the patients inquiring with the PSCs and with the nurses about we got their referral. So just a little bit of kind of coordination there. Because it's on PAS, we're able to monitor the performance in a better way and improve management of the capacity and demand for the service. So we had some good outcomes from this. The metrics measured via a dashboard. We have a new improved process map. We have increased clinical time for the therapy team from rolling out the patient video instead of having pre-treatment visits from the patients. Obviously, if they want to have that, they can have that as well, but it isn't one of those things that we can do with every patient. So a video would suffice, and some dynamic discharge that we didn't expect to have really. It was something of a kind of wish list. So based on the dose measurement that the patient has, we were able to discharge some patients 1 day earlier than originally planned, which was really good. Next slide, please. So this was just a diagram of the pathway. So I've been using Visio for this. The first slide, we had multiple actions within each box. It was very task heavy and we hadn't even identified all of the areas. The latest pathway has accurate identification of responsibilities and we've kind of done each specific task in its own box. So it definitely is in that. Next slide, please. So what went well? So good communications meant better engagement in the task and knowing what we were trying to achieve. Knowing our business means we can identify improvements and even more improvements than what we originally thought we were going to do in the first place. Further improvements have been identified as well from this piece of work. So the patient video was something we didn't expect to be doing. We have a formal staff training plan that's been reviewed, so it's all formalised. And the dynamic discharge was something additional that we hadn't expected to come out of it. So some really good things there. Next slide, please. So what would we do differently? I think with everything, with any project, remain focused on the one task in hand if you can, because we can get overwhelmed with multiple things that come through. You'll always have the spin-off mini projects, put them to one side, work on them later. Continue with the task in hand. I think scope creep is always something we've got to keep an eye on. And key learning. So PDSA, let's do the plan, do, see, act into pathways regularly. So we can just keep on top of that and use root cause analysis at the earliest opportunity. I think if we can kind of get to the root cause of why something isn't working properly, or if there's something delays or identifying bottlenecks, always helpful to do it there and then. So the next steps from this was working on the mini projects that have come out of this and rolling out to other clinical services in the section. So we're going to do this, because now we've done this with radioiodine, we can do this with radium, biotoxics and a couple of the other clinics that we have in the department. And I think, is that it for me? Yeah. Thanks for listening.
Wow, that was brilliant. Getting people home one day sooner is no small feat. That's amazing. I'll save questions or invite questions at the end. I'm sure there'll be a fair few. We'll move on now to Dawn Marie, who's going to talk us through discharges in SIM. Dawn, are you ready? Brilliant.
Okay,
thank you.
So my project was looking to increase the number of discharges that we transact on PAS in real time for our out-of-hours discharges in SIM, and we'd looked at reducing it by 10% a second. Next slide, please. Okay, so the current state before we started this work was that all the admissions, discharges and transfers were done by the Wall Clark team. But the Wall Clark team only work from 7 till 8 and then till 5 o'clock on a weekend. The timely admission of the ADTs assists with the bed managers for identifying empty beds, and that then in turn prevents long waits in the emergency department. If everything's not transacted at the time, then the bed managers have to ring round all the wards, and in SIM we've got 15 wards, so that's quite a task. When the Wall Clarks aren't working, the patients were just left on the system, so they weren't discharged. So the bed managers out of hours were having to ring round, make sure that everyone was gone, and the task was just left till the next morning for the Wall Clarks to return. They pick up the next day. Now, we discovered that the nurses don't have access to PAS. Very few of them do, so that wasn't something we were looking to roll out, but instead the bedboard team who work downstairs in Glentown Wing, they have got access to PAS. They can transact any ADT requests out of hours on receipt of a referral request form. Okay, so next slide. So this was the data at the start of my project in June. So we were looking around about 50% of all the ADTs out of hours were transacted. These are very, very small numbers. So just one missed discharge does make a big, big difference. So next slide. So the first thing that I did was I stayed late for every night for a week, just went up onto the wards, sat there, watched the discharges just to see if it was possible for the wards to be doing the bedboard form. So these are the spaghetti diagrams that I created when I was observing the discharges, and as you can see, they are quite busy. However, they were going on to carbs, they were cleaning the bed, etc. So I discovered it was feasible to input the form. And next slide. So when we started introducing the data process, we did encounter a lot of mental valleys. So what I did in order to get round the whole it won't work was I went to the CLIC meeting, which is a nursing held meeting. I demonstrated how to fill out the form. I did it in real time. The only thing I didn't do was press submit, and it takes 2 minutes. So I just basically demonstrated how quick and easy it was. We also created a really quick guide, which we put behind the desk on the wards so that they had it to hand, so that they knew what they were doing and where they were going. We produced a weekly production board, which we circulate to the matrons, the ward managers, the ward clerks as well, so that everyone can see how they're doing. And when we identified wards that had much lower scores than others, we would go and target them. So we'd speak to the ward managers, we'd speak to the matrons and see if we could offer any further support. We also sought the support of our ward clerk team as well in the process. And not in the scope of this project, we ran it alongside. We started targeting the in-hours discharges as well. And as a CSU, we went from 89% to 91%. So that's just a little bit of something else we did at the time. Next slide, please. So unfortunately, despite all our best efforts, it hasn't actually, we haven't seen the results that we expected to see. So we've gone from just over 50% to around 40%. So we didn't have the outcome we expected. I kept hanging on thinking, I won't come to report out until it's better, but it's got to the point now where I'm just going to have to come. So for the next slide, please. So the things that we did quite well, so shadowing the ward staff, that was really well received. Everyone was lovely. They were really good while I was there. Also having the data to show the progress that we were going through, engaging the ward clerks, engaging the matrons to help us, and also understanding further reasons why we couldn't put discharges onto PAS. So things like we've got some younger adults wards where they'll self-discharge before their EDAN's ready. We can't put them onto PAS until the until they come back and pick up their EDAN. Also people who go AWOL and we're not sure where they've gone, so things like that. Also the medic event that took place in October, that really highlighted some of the challenges that we're facing in terms of flow, and that was a big help. So next slide. So obviously the project hasn't worked, but we're not giving up. We are going to continue with the improvements. So as part of the ward clerk appraisals this year, we've asked them to support us with getting 98% of the transactions for their ward on PAS. So we've said to them things like when they're leaving, making sure they're making the ward teams aware that there's a patient going in the next few hours, so that, and reminding them to do the bed forward form. We've also thought about going even smaller. So we did target the whole CSU because there's only about 8 out-of-hours discharges a week. So we are talking quite small numbers, but they do make a big impact when you've got 30, 40 patients down in the emergency department waiting to come in. So we're going to look at going even smaller, maybe just go onto one ward and see if we can really drill down into what's not going right and see what other improvements we can do from there. Also look at tying it into other schemes that the CSU is running. So maybe like our WRP scheme, if we can find some kind of tie in there, and also to link in with the Ops Centre for some further input. And I think that is me.
Fab for that, Dawn. And I think you're doing yourself an injustice there. There was a lot more green on that side of that heat map than there was before. So you're obviously doing all the right things. And again, we'll save questions to the end and we'll move straight on to Ellie.
Hello, everybody. Can you hear me okay?
We can, yeah. Thank you.
Lovely. I'm Ellie. I'm a dietitian working on crit care. And my project for the LIM study was to look at recycling of nutritional products across adult critical care with the aim to kind of implement a recycling process. Next slide. So just for a bit of background, adult critical care is a really high use area for artificial nutrition support, most commonly nasogastric feeding, and we give this feed through nutritional products and packaging, which prior to the project were being disposed of via domestic waste, despite being fully recyclable. When we looked into it, there was no established process or policy for recycling these products in LTHT, which is where the kind of project started. In terms of challenges, it was the first clinical area to look at this. And there was a lot of different CSUs to involve. So we had dietetics, adult crit care, estates and facilities, as well as Nutritional, who are our feeding company. We did have some infection prevention challenges, which I think we talk about later. And we were introducing additional steps for the nurses. So we were very aware that it was more work in the sort of shorter term. It was quite an easy one to link to the 7 Cs. So we were aiming to reduce our carbon footprint. Next slide, please. So as I said, the project did involve adding additional process for the nursing staff rather than streamlining. So we had to kind of get a bit of support and understand the barriers that may affect the changes on the units. So we identified key stakeholders from the different areas. We had a clear story to try and support change, with that being the kind of environmental and cost benefits that we can bring in. We sort of took the time to understand the barriers from the nursing staff and kind of tried to overcome some of those practicalities, such as IPC for discarding the feed, and actually trying to get a bin, a recycling bin, was probably the hardest bit. Next slide, please. So the LIM tools I used for this project, I identified the relevant stakeholders. I was really pleased that we had a established waste team in critical care, so that was really helpful. And kind of finding people that were really sort of passionate about recycling was really helpful. I did a Gemba walk to understand the thoughts of the nurses and clinical support workers who would be implementing things, and listening to people that were kind of had some frustrations or concerns or weren't engaged in the project. And actually a lot of that was time. So I did complete a time observation to show that actually the additional step was only a couple of minutes, and it was maybe once or twice a shift. So that was kind of well received. We did a lot of mistake proofing. So we made an education video and created some bin labels. We did a lot of dissemination across various sort of CSU opportunities, and we created a sort of standard work, so made an SOP that other units could use across the hospital. Next slide, please. So in terms of the metrics, we were able to link in with eMeds and pharmacy to look at how many feeds we were actually prescribing and giving to patients across a year. And quite surprisingly, the total volume of enteral feeding bottles used in a year was 27,000 bottles. The number of nutritional supplement drink bottles we used was about 6,500. The weight equated to nearly a ton, so 860 kilograms of plastic. And using this sort of carbon calculator, we were able to work out that that was nearly 4.9 kilograms of carbon emissions saved if we were able to recycle all this plastic. So again, trying to use that story, we did try and equate it to what is understandable day to day. Apparently it's 125,000 miles driven by an average petrol car, so 5 times around the earth, or maybe more practically 26 flights to Sydney, or even enough carbon emissions for over six homes energy use in 1 year. Next slide. So in terms of what went well, recycling is happening for our nutritional products across the units. We've had good engagement, sort of to get it implemented, and also help with those additional resources, and some support from pharmacy to help with the eMeds data. And that's just the picture of the some of the visual controls that we used. Next slide, please. So if I did it again, I probably would scale this down a little. 5 busy intensive care units was quite a bold task. So, and there was kind of not a one-size-fits-all process. There are a lot of sort of high-use central feeding areas or more kind of discharge-focused units. So it was a little bit tricky. It was important to ensure all relevant stakeholders were involved at all stages. We did have a couple of duplication things, which on reflection we could have avoided. I do have a greater appreciation for a PDSA cycle, and that you do have to try things again and listen to people and go again and again. The matrix was really helpful to bring people round to new ideas. And yeah, lots of communication is required across busy CSUs. Next slide, please. And then finally, next steps, we're still kind of rolling out this pilot and feeding back nursing comments, gathering more metrics to help hopefully embed it across other CSUs. And there is a cost benefit potentially of plastic rebate and effectively getting the money back into the trust of the recycled plastic that we're able to do. So hopefully we can link in with the states and facilities in the longer term to try and think about more financial benefits. And I think that is me. Thank you very much.
Wow, those metrics, the flights to Sydney, that's blown my mind. That's amazing. Well done. I'm going to open it out for questions and comments, but I do have one first of all. It was so lovely to hear every single one of you talk not just about what we do, but how we do it and how it's so important to think about your stakeholders and have that collaborative working going on. And that in the spirit of the Leeds improvement method, it is continuous improvement when it doesn't quite work or where we've got to pivot and go somewhere else, that we keep doing that so that we're definitely improving things where we can for our patients and our staff. And that on that staff side of it, we can't work any harder, can we? So we've got to work smarter. And if we are adding extra steps, are we being really mindful of that? And are we adding them in the right place? So what a way to end a Friday. But I can see Jenny's got her hand up. I'll hand over to Jenny.
Good to see you all. Wow. So Donna, Ellie and or Marie, first of all, absolutely blown away by the impact. So patients home a day sooner, fewer patients incorrectly being cared in REDs, and all of that narrative, Ellie, that you've just described around the impact on emissions. Just incredible. And I love that you've talked about the compelling story behind your change as well. I'm really interested. I was meeting with the clinical directors earlier this week to talk to them about the value of this approach. And one of them said, but Jenny, we put all of this really hard work in, we make an improvement, and then behaviours don't stick and things dissipate. And as you were talking, I was thinking, how do you keep a picture of REDs when they are full of patients that shouldn't be on trolleys in REDs waiting to be admitted? How do you keep that image front of mind for those that aren't seeing it, but are the ones that need to make the behaviour change and do the task to enable it to happen? And how do we keep the benefit of that? It's just, I'm really intrigued with how we can bring a benefit that is felt over here, achieved by a behaviour or an action over here, how we can get better at bringing to life for the people that have got to make the action, the so profound impact and benefit that has on patients somewhere else. I don't want you to answer it. It's just a thought out loud, really, that after this week, where you just find yourself thinking, how do we keep it front of mind? Because often the changes we need making the benefits aren't always immediately felt by those making the change. I'll leave you with that thought unless anybody's got any bright ideas.
Oh, I've got many, but I think I need to ponder on them, pull them together. But Tracy, you got your hand up.
Hi, Natasha. Thanks, Jenny. I'm Tracy. I'm service manager in older people's medicine, and it was just a really quick sort of an answer to that to you. Last year, we had exactly that thought process, and on the days when we were in bronze and we were leader on point at that point and going through, we absolutely identified that the people on the wards couldn't see that urgency. And what we actually did on some of the days when it was absolutely bedlam, patients were lined up in trolleys, we actually asked if some of the senior teams, and they could then actually ask their other teams in if they wanted to actually take 10 minutes to walk down to ED just to witness in an absolute moment what that looked like. And some of the people that went down were shocked, and it was really difficult to do, and they were saying we haven't got time, and we said it's really important for you just to see we're up here delivering, that we need beds, the reason why we need beds, but you need to come and see these patients. And it was a bit of a realization shock for them. They had no idea, because out of sight is out of mind, and I think that's a really important thing to do, to involve teams and to bring them to areas that they don't necessarily go to on a daily basis, just to see what that's like. And I think that's a really important thing to do, and helps then to drive for them to understand why we're doing what we're doing.
Yeah, Jenny?
Tracy, I love that. And if we could bottle that and help that happen more frequently in our change, so for people to see the bit that we're trying to fix and the impact that has on staff and patients, I'm just thinking about how we more systematically embed that in our change process, so that that compelling narrative is the bit where sadly people are shocked sometimes about the bit they'll do and the massive difference it will make elsewhere. So I'm sure Natasha and Madupe and others will give some thought to how do we really help people understand that the actions and the maintaining the actions, the impact that has on patient care, I think is one for us to just keep pondering, isn't it? But I love that you did that, Tracy. I'd love to see us do more of that.
Yeah, you're right. And that's something for us to take away and ponder. We often talk about the power of direct observation and walking our own Gemba, but how often do we walk Gembas up and downstream of what we're doing, and see the impact in the moment, and also see impact, celebrate the good stuff that's happening as well in there. So that's definitely one for us to ponder and think about how we can introduce that as part of our leader standard work. But Andrea, you have your hand up waiting patiently.
Yeah, sorry, no, it was just to go back on that point as well. Completely agree with what Tracy said, and there's an enormous amount of value on going on the Gemba. I know in oncology we've got the TRI team have got a strategic approach to going on the Gemba, and we've got a timetable of doing that for the year. But then within our own individual business units, there is opportunity for business managers, service managers with matrons, senior sisters to go on the Gemba as well, into their wards and departments. We don't need to restrict ourselves. And the value that comes out of that, I think, from staff engagement is enormous, because actually for us engaging with our ward clerks, they do the business, don't they? They're the people that are transacting this, like our clerical officers. They are the people that are transacting all this important information onto PAS for all of our data. Just want to give a bit of a shout out to Donna. So obviously Donna is within our CSU and has done a really great project there about the radioiodine service. And I think from the work that she's done, it's helped improve the visibility of the patients and the patients within that service with all the work that she's done with PAS. And I'm really pleased. I mean, there have been some challenges, significant challenges within this service, but for her to acknowledge sort of the root cause and get into the root cause of the issues to ensure we're in a better place going forward is really good. So thank you, Donna, for all your work on that. And sorry, just to say as well, I really enjoyed Dawn Marie's presentation, which is it's not uncommon, is it, across the whole trust? And again, going on that Gemba, doing that observation work and working with the ward clerks is a really valuable piece of work. So just to iterate what Natasha said, don't be demoralised with maybe your dashboard isn't as green as you would like it to be. Just keep going. And it's a really valuable piece of work to make sure that real-time ADT is being done. And being done by the right people administrators and not necessarily nursing staff who we want to care for patients. And to Ellie, that was mind blowing. Was your data on plastic waste? So and I share your concerns about being able to get a recycling bin. Difficult.
I will pass that on to Sophie Williams, our sustainability champion, and tell her get that sorted out.
We shouldn't need to ask for them. They should just be there, shouldn't they? But anyway,
they should be.
Fantastic presentations. Thank you.
Yeah, brilliant. Thank you. What a wonderful way to end a Friday afternoon. Thanks for joining us all. We'll see you next week.
Thank you.
Bye-bye.
Bye.